Voigt. I'm a physician with the privileges to practice medicine at Memorial Sloan Kettering Cancer Center, where I chair the Ethics Committee. Thank you for joining the third public webinar organized by the Empire State Bioethics Consortium. The moderators and members on the panel this afternoon and I are all speaking on our own behalf, not as representative of our own healthcare organizations or institutions. I hope that our collective insights will be beneficial to everyone attending today's webinar. On March 23rd of this year, at the beginning of the COVID-19 pandemic in New York City, a handful of us, bioethicists, clinicians, lawyers, and a few other members of healthcare organizations decided to meet to exchange ideas, to discuss the major challenges that we and our many colleagues were facing in trying to care for so many sick patients. The initial handful of participants grew to a much larger group that included people from all over the state of New York and across the country. After several weeks of deliberations, we created a public program to share ideas and wisdom gained from our pandemic experiences as broadly as possible. I want to welcome all of you who decided to join us today on our third of 4 webinars on the importance of palliative care during the COVID-19 pandemic. Our goal is to ensure progress in how we approach this perhaps once in a lifetime challenge and avoid relearning the same lessons. We hope that the consortium will serve as a repository of knowledge that is widely shared and discussed, and that it offers you and us practical solutions to the ethical quandaries that our communities have faced, continue to face, and may face again. As we strive to make the voice of bioethics heard in New York State and across our country, we need that voice to reflect the full range of diversity that exists here. If you work in bioethics, please contact Ms. Claire Murray at murrayc@mskcc.org and provide her with your email address and a short description of your work. We will be delighted to add you to our expanding group. On behalf of the members of the Empire State Bioethics Consortium, I would like to express my deepest gratitude to some of my colleagues at Memorial Sloan Kettering Cancer Center, Amy Schaff, Claire Murray, Nadil Hazel, and Jennifer Polly, who have helped make that program possible. Likewise, as a proud alumnus of the Columbia University Masters of Bioethics program, I want to thank the program's event and AV teams at Columbia University for their assistance in making this webinar possible. Now, I am pleased to introduce Dr. Timothy Quill, professor at the University of Rochester School of Medicine in New York State and moderator of tonight's discussion. Tim?
Thanks so much for your kind introduction. I am going to moderate this, and we have an esteemed group of speakers, which I'm going to very briefly introduce so we can get going. And I have them in alphabetical order, so there's no hierarchy among them. First in line is Eduardo Bruera, who is a world-renowned palliative care clinician and scholar, originally from Argentina, then Edmonton, Canada, and now MD Anderson in Texas, where he directs a large comprehensive palliative care program and is a prolific researcher, scholar, and teacher. Next, Amy Case, who's a respected palliative care clinician and teacher, who is the Lee Foundation Endowed Chair of Supportive and Palliative Care at Roswell Park. Her academic focus and research is on education healthcare staff resiliency, non-medical opioid use, malignant bowel obstruction, and medical cannabis. Next is Domingo Maynes III, who is an associate program director in hospice and palliative medicine at Arizona College of Medicine in Phoenix, Arizona, where he is on the front lines of managing a number of COVID patients from diverse backgrounds in a setting of limited resources. Next is Vijay Periyakoil, who's the director of Stanford Palliative Care Education and Training Program and the Stanford Aging and Ethnogeriatrics Research Center. Her lab focuses on healthcare disparities for diverse populations and the use of technology to improve the aging experience. And then finally, Reverend Melody Rutherford, who is a palliative care chaplain at Roswell Park Comprehensive Cancer Center. She has a long experience in chaplaincy, service delivery, education, and mission services, working with patients and families from diverse backgrounds and facing serious illness. So we really have an amazing group to help us explore some of these palliative care issues around the COVID epidemic. A couple of reminders before we get started. One is our presenters will make every effort to present clinical information that is not identifiable, but you are welcome to discuss in general terms the cases that are brought up here. If there is any identifiable information that slips through, I would ask you to please use discretion and really take that out of the discussion, keep it in more general terms. We will divide our presentation today into 5 initial parts, each lasting about 15 minutes. We'll have about 10 minutes of presentation and maybe 5 minutes of discussion in each one in response to your questions. So please put your questions into the chat bot, and we will be monitoring the chat box and try to derive some questions out of there. The final 15 minutes will be reserved for additional questions from the audience. None of our presentations are scripted, so we look forward to both areas of agreement and disagreement among us. So let's get started. The first question is how to manage the overwhelming demand for palliative care services during the palliative care pandemic. And we will start out with some comments from Domingo.
First of all, I'd like to thank everyone for being here with us. You know, these are some very difficult times that we face, unprecedented, as they say. And here at Banner University Medical Center in Phoenix, which is downtown, it serves as a tertiary referral care center, adding care for various populations that are not exclusive to, but are very inclusive of our Native American populations, of our Latino, Latina, Hispanic populations, our African American, Black populations, and a myriad of uncompensated as well as undocumented patients, which adds to the reason for having such a presence in the palliative care role in taking care of these patients and their families in this time. What we have found is that in order to give homage and pay tribute to these patients and honor their dignity, we recognized very early on the importance of having not only a presence, but an active role in interdisciplinary rounds. And by that, I mean having involvement with our critical care teams, with our transplant patients, with our cancer patients from MD Anderson, who we serve here. Also, those patients who are coming in with cardiac issues, leading to left ventricular assist devices, total artificial hearts. And in addition to that, the morbidity and the high mortality that COVID-19 relays onto our patients. And so with that, what we found is that understanding this gravity, we had to make certain that we partnered in a primary palliative care way with our colleagues, assisting in code status discussions, in sharing with MPOA designations, meaning the naming of a person that the patient, while being able to have cognizance and maintain decision-making capacity, naming someone in the event that they lose capacity, and also having goals of care discussions with short and long-term care goals so that we can hope for the very best outcome and have a very good plan for the next best outcome. And so that's where we supported from a primary care palliative position. Then, as we found as a specialist, we were called into the more complex cases where there are symptom management issues with pain, nausea, vomiting, shortness of breath, any of those symptoms that take away the patient's dignity, as well as navigating, ethically challenging conversations with families and patients. All of this, again, was due to an early recognition starting in late March, early April, that we needed to have everyone at the table, and specifically bringing in our palliative, geriatrics, critical care, all team members, and really listening to our physical therapy, occupational therapy, nutrition, our nursing colleagues, and giving everybody an equal seat at this round table. What we have also found with persons of various backgrounds is that it is so difficult in these times to socially distance when you have multi-generational patients. For example, as a Hispanic male, I grew up in a home where we had grandparents, we had aunts and uncles in and out of the home with us, cousins, the children. There's 14 of us in my family. And so you can imagine in a time, if this same situation were presented then, you could see how easy it would be for a whole family to have the risk of being afflicted by COVID-19, and then how to care for one another, how to maintain not only each other's best interests, but also trying to mitigate fear and reduce those things that come with anticipatory grief when a patient is not doing well.
Great, let's have some of our other discussants pipe in a little bit now.
From the spiritual care point of view, just going into the room, visiting patients during this very trying time, our job is to go in there and to really to support their spirituality. We continue to offer a listening presence, just being there, just encouraging them. One thing that we found out, that there was a deep sense of loneliness in the room and a deep sense of fear. And many were afraid that, that something just terrible was just happening outside of, where they were. And I think that was because, so many people were just glued to the news, and so too were the patients. So there was just a deep sense of fear and loneliness. Even for our non-COVID patients, just going in there, first of all, they wanted to make sure that you, as a medical care worker, that you weren't bringing COVID into their room, into their space. So what we had to do, we realized that some of the visits we had to conduct by phone, what we call the telephone. And, I found out that what was missing in those times were the sense of touch, because so many of our patients, they appreciate when you reach out and touch their hands. They appreciate when you reach out and touch their shoulders. And we weren't able to do those type of things. So we had to be a little bit innovative with our cause. And so it did not stop us from really fulfilling our role as a chaplain, because we are in there to support their spirituality and any other kind of emotional needs that they may have had.
I can add to that, and layering on what Domingo and Melody said, overwhelming demand is, I think in this case, an understatement. What I saw in my experience and in talking to many of my colleagues, we went from being adequately staffed for our service to overnight an area of complete uncertainty. Everything was chaos. There was no more advanced care planning because everything was present care planning. This pandemic obviously initially there was great uncertainty. We did not even know who was at risk. We subsequently did find out that older patients and patients with hypertension and diabetes and cancer and other immunocompromised patients were more at risk. But when it first started, because we were dealing with complete unknown territory, not only was the demand overwhelming, we were sailing in uncharted waters. The news every day, anytime you start seeing CNN, your systolic blood pressure shoots out through the roof. So it was challenging in ways that all of us really struggled. And then from in our roles as specialists, we typically rely on our colleagues, whoever consults us and puts in a palliative care consult, we take that and then we work on that. But now suddenly the services were getting overwhelmed, and I definitely know that working with my colleagues in Colombia, they were just doing heroic, like beyond heroic measures in terms of the volumes that they were facing. So when people like me were volunteering for them, we would get statements from our colleagues saying, oh, that's wonderful. I actually get to go home now and have a shower and have dinner and then come back. So what I learned was, while it was incredibly overwhelming in unprecedented ways, I also saw unbelievable heroism. How people were, I mean, selfless is the word that comes to mind. Selfless, putting the needs of the patients and families first, trying to provide the best possible care all the time, foregoing sleep, foregoing rest. It was just an incredible, humbling opportunity to be serving at a time of such extraordinary need. And clearly, we always, in the field of palliative care, we always say that the unmet need is huge and we are barely scratching at the surface. Well, this made that exponentially higher. So I think we were only seeing a fraction of the fraction of patients who needed to be seen. And so I think the most important strength that I found personally is really relying on the collegiality and trusting my colleagues and counting on them and working with them seamlessly. And the barrier, while I was in California, in this specific case, volunteering for New York, the 3,000 miles disappeared. It was like we were in the same room working on the same situation together. And I think that was extraordinary things that I feel privileged to witness. So yes, the pandemic is devastating, continues to be that way, but it's also provided great opportunity. I'm looking at a silver lining in a nuclear cloud here, but it provides great opportunity for growth and getting closer together. And perhaps, something that we've been talking about for a long time in terms of fixing our healthcare system. Well, if we need a clarion cry for that, this is it. It doesn't get bigger than that.
At our institution, there was an overwhelming demand as far as wanting to support. And so I think that our colleagues were asking for support for patients, and our administration was turning to Palliative to ask us our advice on some bioethical concerns. And then our colleagues were also turning to us looking for some mental health support. So I found that in the midst of extremely high volumes and ever-changing daily schedules and trying to convert things to virtual visits and lots of different changes every day, we were being asked to write policies and come up with new ideas. So I found that balancing the administrative requests and also the mental health requests of just the patients, the families, and our colleagues to be quite challenging. And so our team was running on empty. We were isolating from each other even. So normally when a palliative team meets as a group every day, we huddle in the mornings. We weren't doing that for a little while. And we all, I think, started to feel isolated from each other. And so we tried to connect by phone and by WebEx video, but it still isn't the same. And so that loss of connection for us palliative folks are all, we really thrive off connecting with each other. And, we tend to need that. So I really felt down, and I think a lot of our colleagues felt the same way. So we were being inundated by more consults, and we still actually are. We're down a provider, so it's just been extremely busy. We've, every day is just more and more consults just piled on, and it just the part that's really troublesome is like, is there going to be, an end, and when is that? And so the unknown, I think, makes it really scary for people.
I'd like to echo what everybody said. That is wonderful. And one of the challenges we faced was an enormous educational need. A lot of our clinicians, our colleagues, were now saying, I need to speak in a different way with the patients and families. I need to communicate in a different way, and I need to do that pronto. Can you guys help us develop scripts, way to communicate with our patients and families, not only patients with COVID, patients with cancer, patients with CHF and other conditions who are now having a different prognosis. The crisis hit absolutely everybody who had a chronic illness particularly. So the treatment of cancer, the treatment of other conditions badly suffered as a consequence of this crisis. And so our colleagues were looking for our help in dealing with the personhood issues, but they also needed help in communication about the disease-related issues and how should they tell to the patient that they were truly palliative, that they were not going to cure them, and that prevention of escalation was necessary when they had not done that very often before. So I think Vijay mentioned so appropriately the issue of the silver lining, and one of the silver linings was that a lot of people understood that they had to learn how to communicate rapidly, effectively, and much better than before. And it gave us an opportunity to really go out there and show them, in a sense, how to do that, and to guide them and to accompany them to the bedside, going together with them and saying, let's have this conversation with you. Let us, you are the boss, you are the oncologist, you are the surgeon, but let us help you do it in such a way that nobody gets bruised and everybody learns from this. So that was one of the wonderful opportunities we had. And I like to echo Domingo and Amy's point, and I think Vijay's too. As this gets longer, what is absolutely clear is that our institutions did not plan their palliative care teams with the size that needed to have. And therefore, as this gets longer, it's become clear that maybe the number of people doing this type of work in our medical schools, in our hospitals, is not the one that should be there, and that efforts need to be made to do the recruitment. And the people are there, particularly for the big academic institutions. It's just a matter of creating those jobs, and people will come.
So let's focus on that a little bit more in the next phase of things, about any creative ways that people found to both teach about this but not do all the consults. So there's a tension between teaching about it and having others do the consults who are on the front lines, and us doing the consults as consultants. So again, maybe we'll start with Vijay on this section. What are some of the challenges of pulling that off, Vijay?
It really, the metaphor that I will use is that it goes from the street view to the 30,000-foot view. If you are still thinking about the one patient in front of you, what about the 1,000? And by the time you start taking the count, it becomes 10,000. So it really made us, in a very serious way, think about population health management. And how do we, as palliative care experts and subspecialists, work with our colleagues? And I will layer on what Eduardo said earlier about the huge gaping need for education. So as people were trying to do these urgent goals of care discussions, they found that, of course, patients were usually in distress. So as I was thinking about where those points were, when the patient comes to the ED, breathing at 30 per minute, and then sort of getting a little worse, there is that point there where do you want to do intubation versus not, what does the patient want, and sometimes it's very hard to talk about that at that particular moment. Families may not be there, so that was a challenge. Once the patient does get intubated, then what happens, as I saw it, was they become chronically critically ill over the next several weeks, and the families were not able to visit them. The families were completely unprepared and surprised about all this. In terms of the primary care team and the ICU teams taking care of them, just as Eduardo said, they needed a different vocabulary of how to have these conversations. And it's like you need insta palliative skills. Those of us in education, we always talk about the attitude barrier, thinking about knowledge, attitude, skills leading to change in behaviors. You always think about the attitude barrier as being the most difficult to overcome. Well, guess what? When the pandemic puts its shoulder behind you, and when you talk about it, your attitude barriers are more easily overcome. So many people came to us and said, we need this help, we need this language. So I'll highlight efforts done by our colleagues, Diane Meyer and Sean Morrison and the CAPC folks in Mount Sinai, our colleagues in Harvard, where they put together this, the folks who are doing the serious illness conversation, Vital Talk, all of them sort of came out and started putting in resources free that are available. My colleagues at Stanford actually have done that, not only specific to palliative care, but also looking at what do other stakeholders. It's not just about the doctor, patient, and family, right? It's not just that. It's about, as Melody said, what about the other interdisciplinary team members? What about the nurse managers? What about the janitorial staff who are seeing disproportionate amounts of death and having to clean up the rooms and the morgues are piling up? Everyone needed some amount of education so that they can handle their shock better. So it's all of those challenges. One thing that I will do is I'm a strong believer of bringing the patient's voice into the room. So I will quickly tell you a story that touched me very much. A 71-year-old gentleman who was admitted from an underrepresented minority background, a beloved father, amazing grandfather, who was admitted with COVID-19 and then was in the hospital. Initially came in with dyspnea, was admitted to acute care for observation, quickly transferred to the ICU, and he became delirious. He was unable to talk. Even when he was able to, he was not decisional, did not have the mentation to be able to make decisions. And his daughter actually had the infection, COVID infection, and so she was isolated. There was tremendous guilt from her side, thinking maybe, did I give it to my father? How did this happen? And so there was that. And then over a period of time, as my patient became chronically critically ill, he started, it was very clear to when my colleagues consulted me, when you come in as a consultant with as a subspecialist and you're standing very far away and you're not the family, you're not the primary care at the bedside, you can quickly see that this was a downward trend that was rapidly escalating, and patient was on maximal ventilatory support, multiple pressors, on dialysis, and so it was pretty clear that the patient was not doing well. So what we did was I had a family meeting through Zoom because of the emergency provisions that we are actually allowed to use Zoom and Doximity dialer and other tools to have these conversations. And initially the family was so unhappy and worried and anxious, they didn't even want to talk with us by video. And then eventually, once they built a trusting relationship with us, they started talking with us. And the biggest question that they kept asking, I actually remember the first conversation very vividly because they were crying loudly. And that was very unsettling because it was so unexpected to them. And they got a call from the hospital and they heard my voice. They immediately thought the worst and they were terrified. And then I talked with a number of family members. And the first question that they asked was, are you calling to stop everything because you've reached the 2-week limit? They kept asking me about, is there a 2-week limit? And I was genuinely puzzled. I said, what 2-week limit are you talking about? And then they said that they had heard the word on the street was any patient gets up to 2 weeks, after which that's it. we stopped treatments. And I said, that is absolutely not true. That's not why I was calling. I was just calling to check in. So a lot of the initial calls was just to set up a rapport, getting them to trust us. And over the next several days, I mean, I won't belabor the case. The gentleman eventually passed away in the ICU after we did palliative extubation. But I do want to read one thing. So the patient's daughter, basically the question that, sometimes you ask this question and it opens up a dam of emotion, and out it all came pouring. So I said, okay, we've talked about disease. Now let's talk about your father. Tell me more about, let me get to know your father a little better. And so she said that he was a loving grandfather, used to go to all the baseball games. She had multiple children and like 3 or 4 kids. I don't remember the details, but as it turned out, all of them were out visiting other people. So they were all sheltered in places in different states. She was all alone, and her rest of the family were in different places. And so she was terrified that her father would pass away as an unknown person, uncared for, unknown, as an anonymous person. And so what we did was we were able to get her to write a little letter that we put at the bedside, and we were able to read it out. And so I'm just going to bring the voice of this family member and the distress, and I'll try to do it de-identified. So she says, "Hey dad, this is daughter's name. I know you're confused and feeling alone, but you're not. You're far from alone. Not only am I right here fighting for you, but so many other people are as well. You're definitely a loved man. So many people are praying for you, asking God to heal you and push you through the situation. Dad, it's time to trust in God and let Him heal you. I know He's going to bring you out of this. We trust in Him, and we know you're a fighter. So fight, we need you to fight. Get your lungs stronger and better. Multiple names, they all love you, can't wait for you to get better so they can see you. Hey, don't forget, we have to catch a flight to fill in the blank place this summer to see name of grandson play and beat and kick some butt. Grandson is already joking that you're going to get on the plane and you're the loudest in the gym. You know how loud you are. LOL. Lot is going on right now. I love you so much, Dad. Remember, you will always be the strongest man in the world for me. I'll stop there because I think that says it better than I can ever hope to.
So there's a comment in the chat, Vijay. Your story is an amazing story of it took a lot of sophistication to respond to, but we're also in the process in many places of having non-palliative care students and social workers kind of in seeing patients. So what can we do to help them out during this phase?
I think that is a fantastic question, and this is a huge opportunity for us in palliative care. We are always talking about the need.
Actually, I'm gonna interrupt and let one of the others respond for a little. Is that okay?
Yes, absolutely.
Yep.
If I say one thing, I'll just say one statement, Tim. To your point, I actually had the fellow be with me on every conversation in spirit of watch one, do one, teach one. And the next one, when the fellow did it, I watched them, and that's how we did it.
So someone want to pick up?
I'm happy to comment on the next, the chat question, which is what sorts of bioethics questions were you being presented during the pandemic? Because I really we struggled with a lot of bioethical questions, and I was called upon in the height of the surge where all the ICUs in the whole city were filling up. And, I work at a cancer center, and the ICU was getting full with COVID patients. And, we really weren't sure how bad things would get. They were calling on us to write, allocation of ventilator protocols. And so I kind of led this initiative, and that's part of how I joined this bioethics group with the downstate folks. And there was a lot of anxiety about the allocation of resources, whether it be enough staff demand ventilators? Would there be enough ventilators? And all my administrators were very worried about this. But I found that in the leadership meetings, people were kind of afraid to talk about it. It was not something that people wanted to bring up. I think everybody was quite scared that, you know, things could get really out of hand. There was a lot of unknowns. I had a case, and I'm not going to go through it at length, but there was a famous case here in Buffalo that was in the news that a patient had been on a ventilator for 5 weeks and then ended up surviving. And she was somebody we were intimately involved with, and we ran family meetings with full PPE, head to toe, with my cell phone in a plastic bag at the bedside, being the only person in the room. Melody was involved in that case with me. She was an African-American female, very, very religious, Pentecostal. And this woman needed to be trached, and she was on at one point unresponsive and not waking up off sedation, and had renal failure. And we suspected that the sedatives hadn't worn out of her system, and you know, the weeks were going on, and she was not improving mental status-wise, and but her lung status was improving. And so we were hoping she would kind of hang in there, and her family were very hopeful. And we went in, and you know, I was asked as the palliative provider to put oil on her head, holy oil, because not everybody was able to go in the room. And through the phone, you know, they were praying really loudly, and hearing the familiar voice really, I think, helped the patient. She kind of came out of her delirium while she was on the vent. One of the ethical dilemmas that came up with this case was whether or not to do a tracheostomy on her after she had been intubated for several weeks. And, you know, it was posed into a physician COVID group on Facebook, and there was much very heated discussion about this. And the ENT surgeons were really uncomfortable because she remained COVID positive, and with the aerosolization and the risk to the healthcare providers, whether or not that should be done. And the standard of care is that's usually done after a couple of weeks. And so it was delayed and delayed. And they had demanded that she be COVID negative before they would operate on her. And so it was brought forth to the ethics committee. And as the palliative provider involved in the case, there was a lot of moral distress about this case. And I think that the ICU attendings, all the way down to the fellows, we struggled. There were a few kind of disagreements among colleagues. The ENT surgeons, you know, really struggling with whether or not that they felt comfortable doing this. And at the end of the day, you know, I had a lot of differing opinions from people all over the country. Some people saying, well, that's not a problem at all. And then other colleagues of mine saying, well, why don't you just take her off the ventilator? She's going to die. What's wrong with you? Why don't you, make her DNR? And, you know, and I would try to say, you know, that the purpose of palliative care is not to, you know, make somebody a DNR. You know, it was really to figure out what the goal of her care would have been. And the family was 100% on board with continuation of treatment with the hopes that she would improve. And sure enough, she ended up literally walking out of the hospital after being on a ventilator 5 weeks. So she was kind of a miracle. And I know that we did lose other patients, you know, when they, especially those with advanced cancer, who she only had like a limited stage myeloma. And so she wasn't as sick as maybe some of the other ones who we did lose. But this case kind of highlighted a lot of ethical dilemmas that we faced, and also moral distress with staff.
Were any of you taking care of cases where you actually had to unilaterally stop against perhaps a patient's or family's wishes?
I can speak a little to that. This is Domingo here again, Domingo Maynes. The situation, you know, that we find ourselves in at times, and I'll speak to a specific, very just sad, ethically charged case. You know, gentleman found down, was brought into the hospital, John Doe, and no family, no identification around. Patient does come from, you know, a Native American background. As per the emergency medical services, they knew of the gentleman, but he kind of went by, you know, a couple different aliases. And so we started reaching out through case management. Again, this is a team effort. And so using one another's strong points and leveraging each other, also bringing aboard our chaplains, they were able to help pitch in some extra time to help search through the white pages and some of these other modalities to find family. However, when we found the family was all suffering from their own infections up in the Four Corners area of, the Utah, Arizona, New Mexico, Colorado border area, with not being able to come down here because they were on their own quarantine and lockdown, shut down borders. And so family had to make the difficult decision to reach out to a half-brother who was very estranged from this patient in order to make the 1 hour, one-time visit at the end of life. And what we find in those situations is even when the person comes to visit, the heaviness and the distress with having to make decisions such as, do we now place a do not resuscitate order, or do we keep things full code, meaning chest compressions, shocking of the heart, maintaining intubation with the breathing machine? Do we continue that pathway, or do we now, looking at a multi-system organ failure, allow the patient to pass with respect and dignity in what's called a compassionate extubation and comfort cares, essentially hospice care? And that half-brother who came here was actively grieving, and the staff was distressed because there was thought that this person may have breached security to come in. And so there was a little bit of a back and forth with security, even though it really was not an issue. It was the person had obtained a pass. I say all of this because there's multiple levels of suffering that are going on. That from being found that this John Doe is now passing away, even though the family, was very close, couldn't come down here. The person who then does come down here is estranged for many years and loves his brother very much. And so he decided to continue full code. As the patient started to deteriorate, we had to invoke what is called a two-physician DNR, or a unilateral DNR. Here at Banner, we are positioned to make sure that we give patients and families the due process to try to come to a resolution with all the facts. But facts do not always coincide with what the heart. So the mind and the heart aren't always on the same wavelength. And we have to give respect and really understand that type of distress can occur. And so in letting the family member know that we would give 24 hours for them to try to seek further care, they finally came to a resolution, at which point we didn't even have to do a two-physician DNR, but we got our ethics team also involved, very much tried to understand where this distress was coming from. And it was the guilt of not having been together with this brother, of having seen and known through social media outlets that he was getting into trouble and needing more help, but feeling as though helping him would be enabling him. So lots of layers of complexity. The family members who are up in the reservation area, we're just so grateful that we were able to finally bring some peace to them. And then in the traditional ways of this Native American family, being able to help bring him back to the reservation to be with them and buried in their way.
So I'm going to shift gears now in the interest of time to ask Eduardo maybe to comment a little bit on the logistical challenges that you found both in making these kinds of decisions and in such complex places where family is present but not present. So you want to comment some on that, Eduardo?
Thanks, Tim. I think it's been a rapid learning for all of us about how to get the family involved in an environment like where I work at MD Anderson. We have the largest concentration of immunosuppressed people in the world, and therefore COVID can be absolutely devastating in a very short notice. And so the restriction of visitors was an incredibly difficult moment for the patients and for the families, both in the inpatient and in the outpatient area. So one of the things we learned, and we learned it ourselves, we just went on and did it, was virtual. Use whatever, use FaceTime, Zoom, Skype, whatever, and just don't let the lawyer know, but we're going to do whatever can get the family into this meeting. And so making the family part of the meeting is reassuring to the patient and is reassuring to us because they know the patient. And a lot of the consults we get in palliative care, COVID and non-COVID, are in delirious patients. And therefore, the participation of the loved ones was enormously important from the very beginning. So getting them into the meetings in the inpatient and outpatient areas was one of the first challenges and one of the main opportunities. The second point is many of our wonderful colleagues, I think I heard Vijay, I heard Domingo, and I heard Amy comment on the moral distress that happened to the palliative care teams, and also the risk and the illness. And so from the very beginning, we emphasized the importance of team self-care, and we started reporting every day, and we started we maintained 100% of our educational activities after the first week of shock, because we knew that that brings community together. And that participation in case rounds and round rounds and education was important to maintain the morale. Then we came with another big challenge that is, and I think Tim very appropriately alluded to this, a lot of people had to start delivering care and they were not sure if they were really delivering care. So we had to come up to the basics of don't just do something, sit there, be present, ask how they're feeling, and that is not assessment, that is therapy. Asking people the ISAs and having them tell us how they're feeling was an important way of making the patient and the family be heard and participate. So reassuring the team that even when things look very bad, the presence is greatly soothing, and not feel incompetent or impotent, to feel that that presence might not be as long as normal, might not be as tight as normal, but it's still greatly meaningful, was another way of keeping the team or trying to keep the team as suffering less moral distress and less overall stress. So strategies we learned faster than we thought we could, and I think there's still a lot to be learned. The tragedy of not having enough PPEs to be able to really get there and do what we do, right? Touch people, examine people, and so on, was there and is still there. The tragedy of not having enough PPE for those family members to be physically present and so on, it's still there. But we focused on what we could do. We didn't focus that much in what hospital policies and the country and everything else. We focused on, okay, we got a bloody mess. What can we do a little bit better around this right now? And by doing it once in a while, I think that has kept the team going. It's still not over. Certainly it's not over in Houston. It's not over in Arizona. It's not over in the South. And we still don't know how many will get hurt. In Wuhan, a lot of people got hurt. In Argentina, a program that I've been mentoring for many, many years, the most important palliative care unit, 100% of the physicians, 100% of the nurses, and 100% of the patients got sick. So the unit had to close the Tornu hospital because of massive contagion and illness, and they're still rallying from that. So we learned from that. We knew that virtual care was necessary. We knew that protection was necessary. And we also knew that there's a double frequency of injury that is related to stress among the teams as compared to injury related to COVID on the team. So protecting ourselves, it's still not over. And I would emphasize that that would be a great thing to do. I have to say that one of the things I was tremendously grateful was this wonderful community. The fact that with the ADCC centers, we initially started communicating with each other and helping each other, sharing stuff that was present, and also the totally unsolicited offers from palliative care colleagues in the nation. Hey, can we help y'all? I mean, we know that you're kind of a bit overwhelmed. We can do distance consults for you and so on. And we never asked for that, but we didn't need to ask that. The impact it has on our morale was absolutely amazing. So I'm grateful to work in a field where this type of compassion and collegiality is still there.
So any other creative approaches to some of these restrictions that you all came up with?
At Roswell, the palliative team was put in charge of lifting restrictions to the visitation policy, which based out of Governor Cuomo was really, really strict. And so we found it to be very stressful to not, we had several cancer patients who were dying, who weren't even dying of COVID, who were dying alone. So we had a 23-year-old, they weren't ultimately dying alone because me and my team were throwing tantrums to try to get the family to visit. But had we not, if it was left up to policy, it would have been very tough. And so, we had a patient who was quite wealthy, and he was a donor, and he said, I'm going to land my helicopter on the ceiling and break into Roswell and be by the side of my wife. Now, when I pled the case that way, it seemed that, oh, let's let him visit. And then, we have other patients who might be Medicaid and, maybe don't have as much clout. And I didn't care. Like, I treated everybody the same. And at the end of the day, I had a 23-year-old speaking to his father with metastatic CA who ended up dying within a few weeks after this time that I'm talking about, was calling his father from the parking lot because his father could not visit him, and he was in his room alone in the final weeks of his life. And he did not have COVID, but he was dying of cancer. And the loneliness, I threw a major tantrum, and I said, we need to do something, and I don't really care what the governor says. And it was, we barked very loudly. And so our CMO put the restriction of visitation in charge of, the palliative team was put in charge of determining how many visitors, how long they could stay. And so all of a sudden we were getting paged by every floor in the hospital, all hours of the night, to ask us, can this person visit? And, I was getting those calls, and I was happy to take the calls because I was like, yes, they can. Yes, they can. I think we maybe said no once. And maybe I am, causing the COVID outbreak in Buffalo, New York. But at the end of the day, if you're in those rooms and you see how lonely these people are, it's just heartbreaking. So I think we bent the rules, and don't tell the governor, but we bent the rules a little bit. And I don't know if other centers did this, but we emailed people across the country asking, like, what are your visitation policies? What are your visitation policies? And everybody's saying, like, only a couple days to live, they'll allow the visitor. To me, that was completely not acceptable. And so we put them in PPE and we let them visit. And then we also, of course, did video chats. And pretty much every consult we saw, we made it mandatory that we provided a video meeting, not only to do family meetings, but to actually have a visit. And a couple times, it was the only time anybody who had ever done that with a patient, and they had been in the hospital for weeks. And it was the only time someone bothered to set up a video call. So it was when palliative came in and did that. So, the question is what is challenging for you as a physician? I've never practiced medicine this way. It was extremely hard to not be able to have families there.
I'm going to shift our gears slightly, even though I would love to have this keep going on in the way we're going, but disparities have been spotlighted in terms of disproportionate morbidity and mortality in COVID, and particularly in communities of color. And I want to have a number of you really address that, starting with Melody, just how you thought about that, how you've approached it, what it's meant to your team, what the conversation has been like in your hospital and your team around these kinds of issues.
You know what, and speaking about disparities in healthcare, I cannot ignore the elephant in the room, so to speak, for minorities and myself, a woman of color, because we find ourselves facing a twin pandemic right now, along with COVID-19. Racism has been pushed to the stage, so to speak, and many are forced to talk about it, to deal with it, and to, either to learn about it. The sad truth of the matter is that disparities still remain in healthcare for minorities. Even besides COVID right now, one of the things that I've been seeing on social media and also on the news is that the news about how African-American women are receiving inadequate care in regards to childbirth. Today, I read a really crazy story, and it talked about how a doctor had assumed that the pain level in an African American woman is better tolerated within them rather than with a white young lady who's having childbirth. So much so that they don't even, well, this particular doctor didn't even think to offer more pain medicine because he thought the pain levels were just so different. You know, those kinds of stories increase the distrust for Blacks and other minorities toward the medical system when they show up for care. So there is a deep sense of distrust towards the system as a whole. And I think the problem is because there is cultural thoughtlessness and is often the main case for disparities. Many people in the Black community have experienced denial, you know this, of access to equitable housing and education, and also healthcare. And the truth of the matter is they don't see a whole lot of doctors who look like them going into the room to take care of them. And therefore, there's this sort of suspicion that remains. And you know the old song that, you know, Elvis used to sing, "We can't go on where there is a lot of suspicious mind." And so the doubt and the misgiving is now steeped and it's boiling over now in anger, especially now in these trying times. Now, in terms of, in regards to COVID in the African-American community, early on, many didn't believe that the story that was being told on television. You know, many people in our community, we thought that it was just a hyped up flu, especially in social media. You know, there was just a lot of stories going on. So, you know, there was questions like, who do we trust and how do we know the truth? A lot of African Americans and other minority cultures are really into special foods, hoping to boost their immune system. And the truth of the matter, families couldn't get these special dishes to their families. Even now, when I go visit patients as the restrictions are softening, you know, their families aren't able to bring in special little meals that they would prepare. And, you know, right now, a lot of the patients tell me that their doctors are not even encouraging them to take a part of the natural remedies that they would, you know, normally do alongside their medicines. Early on, I met plenty of people who had expressed anger because they weren't tested soon enough. I'm thinking about this one patient. He felt like if his symptoms had not been ignored, then maybe he wouldn't have, you know, he wouldn't have experienced such negative consequences. In regards to spiritual care towards the African American, many firmly believe, and I'm just going to say this real quick, many firmly believe that we are a spirit, we're living in a body, and we have a soul. And the spirit is emphasized first because to us it's the most important part, and we feel that it's going to live on next to, you know, when we leave this place. So oftentimes I'm thinking about when a medical professional goes into the room and tries to speak to the patient, you know, when they enter the room and they start talking about the failing part of the patient, you know, right away there's a turnoff in our community because we don't feel that the doctors are getting who we are. We don't feel like the doctors are really talking to the whole part that we are giving them. And I think that, you know, that in and of itself creates a divide. So, you know, we have to be mindful that there is a desire for comfort and love and eye-level conversation that many of the palliative doctors and workers, at least at Roswell, they seem to give that. So I'm just happy that as a spiritual care worker, when I go in to see the patient, you know, I know how to take a seat. I know how to look at them at eye level and just really give them the personal attention that they so deserve.
Domingo, you want to comment some?
Yes. So as a Hispanic male, I'm Mexican American background, and you know, with the ability to connect in Spanish with my patients and their families, it gives you sort of the instant street credit, but from there you then have to again listen and hear what the story of the family and the patient is. Who are they? What matters most to them? How do we pay honor to this person who is dehumanized in a gown, who is tied to the bed with IV lines in their arms and their neck, who may be on dialysis, who are depersonalized with the breathing tube. How do we give a voice and how do we give respect to that person in a way that is meaningful to, for example, these patients that I am able to speak Spanish with, and talking in terms that are familiar to them, in ways that, you know, with some lighthearted jokes about the food that he would be eating or she would be eating if they weren't in this state, and what they would be doing together and how they would play with the grandchildren and the kids. Those are all things that start to make the person in front of us a whole person again. And that's when you start to demystify what palliative medicine is. You start to demystify the medical community and all the misgivings and mistrust that may have been built, you know, in years past, and really trying to broker that type of a conversation with them in a way that is meaningful to them. And so we are privileged. We're in a position to try and really, again, do what's in the best interest of the patient. But the only way to know that is to partner with their family and to hear them out. And in those situations, we have less and less ethical issues, and we have less to physician DNR, to physician withdrawal of care. That should be the exception and not the rule.
Others want to comment, particularly as we face these, we have a lot of people who've been dying, right, in the hospital, and that they are reaching a point of what might be considered futile care, or that they're not going to get better. And that whole conversation is an extremely tough conversation to work through in any meaningful way, particularly if there's a gap of race or color that's involved in that. So be interested in others' comments.
Yeah, I think Melody and Domingo were so eloquent in talking about how to work in the local environment and work with individuals. What is alarming to me is, if you just look at the numbers, the age-adjusted mortality rate of COVID is 3.7 times higher for Blacks, African Americans, 3.5 times higher for Indigenous people, 2.8 times higher for Pacific Islanders, 2.5 times higher for Latinx, and 1.4 times higher for Asian Americans. So those are numbers, right? But how is that possible in our country, where we have the best possible healthcare in the entire world? How is it that the mortality is disproportionate? And of course, it leads back to centuries of structural racism, inequities that have plagued our healthcare system. So the best solution for this pandemic is social distancing. These patients actually work in social proximity because they do daily wage work. They cannot take time off. They don't have insurance. They are non-benefited positions. They work in proximity. For example, our nurses' aides who are bathing and providing activities of daily living care to our patients and feeding them. You can't feed someone 6 feet away. And no matter what PPE you wear, there's not enough protection. And so that I think is a societal issue for us to really think about. And we talked about PPE and the shortage of it. But another tragedy is when African American men and brown men can be stereotyped as criminals. And so many of them have expressed concerns about wearing a mask. So when we think about it, there are strategies for individual organizations, but we have to deal with this disproportionate mortality, morbidity across the nation. And if we cannot solve it in the US, who's going to solve it? And that's something that we really need to think about, because that's an ethical, moral, social healthcare dilemma as far as that's my point of view on that.
Okay, so let's shift gears a little bit toward coping with loss, grief, and bereavement, and self-care. And that's been a challenge, I think, for everybody on the front lines, right? How do we do that for ourselves? How do we do that for our teams? How do we do that for others who are part of our environment? So maybe starting with Amy, we'll have each of you comment on strategies that you've found meaningful or useful to try to enhance this experience in those domains?
Yeah, sure. I'm happy to speak about that. One of my interests is team resiliency, and I think a lot of palliativists look to this as something that's important, is because in a way it's palliating ourselves and palliating our colleagues when we're taking care of each other. Where I work, there were a lot of death. There's a lot of death anyway at baseline and a high risk of burnout. And resilience is really the way we try to educate ourselves to take care of ourselves. And so, there was a study done out of JAMA Network that showed up to 50% of nurses and physicians are depressed, anxious, having distress related to COVID and all of the changes in our workplace. And, there's just the total large sheer numbers of patients and volumes, and basically just hierarchy of needs being met. So people having hours of being in PPE and, on the front lines, at the bedside, seeing death, over and over again. And I don't know if you saw the New York Times article, Dr. Breen, that had killed herself as a result of depression related to post-traumatic stress from working in the emergency rooms in New York City. And that case, a woman who had never had any issue with mental illness in the past, a very well-adjusted physician, basically it's being viewed as a COVID mortality herself, which was the mental health, they call it the fourth phase, right? Is what we're seeing now, is that everybody is anxious and down, and the social isolation certainly doesn't help. And, patients dying, patients and families not being able to have the rituals of funerals. There was a colleague of mine who lost her son to suicide, and I couldn't attend the wake because the wake was just restricted to family. So those types of things are quite heartbreaking. And, you think about the work-life balance, and, that hasn't been brought up yet, but, some people were working remotely from home. Our team wasn't, but there were several people at our institution who were working remotely, feeling isolated from their colleagues. And so part of resiliency is connection in the workplace, having friendships, being able to talk to your colleagues, walking over to their office, meeting together. And so when you're not on site, not everybody's in the same room meeting, there was definitely an isolation, and people were feeling pretty down. And so trying to connect with creative ways, using the virtual Zoom meetings and things like that, were ways of trying to solve that. Turning the news off, and having a spouse at home, and children at home who weren't at school, I think added the stress. People having financial hardships because maybe a spouse lost their job. And so the essential healthcare worker is trying to kind of go to work and take care of these COVID patients, coming home with the fear that they may have contracted the illness, and then are now giving it to their family who are out of work, and, children who are out of school at home, and, having to quarantine and all kinds of things. I actually went through that myself. And, that type of thing is quite stressful. People have a lot of fear about that. So how do we stay resilient? And the definition of resilience is really the ability to bounce back after adversity. And are we able to do that? And I think that not everybody responds to a pandemic in a quote normal way. I think that there's really no normalcy in the state of a pandemic. And so you have to cut people a break. And so as a manager, as a team leader, I really tried to give people the benefit of the doubt. Some people were blaming others. Some people were had maladapting coping mechanisms and things like that. And so we tried to encourage gratitude. We talked about things like meditation, that one size does not fit all though for resiliency efforts. So self-care could just mean going out for a walk, getting exercise, trying to get enough sleep, eating healthy. These are basic things, but I think many healthcare workers were not doing these things to take care of themselves. I loved Eduardo's comment about maintaining education. I think in the midst of a pandemic, that's pretty high level of functioning, because I know that some of ours actually fell by the wayside, and it caused probably a decrease in resiliency. And after that picked up again, I think we were all feeling more collegial towards each other. But palliative teams really have the job of trying to support one another. Here at Roswell, we formed a peer network, peer-to-peer network, and it was all volunteer. And we took call for each other. So physicians took call for physicians, and nurses took call for nurses. And we were there 24 hours a day, 7 days a week to take calls for our colleagues. And if they were stressed out And believe me, I was called by some of my specifically ICU attending colleagues, and they were freaking out. They were very worried about patients being full codes, and what if I have to code them and I'm, going to be spattered with COVID, and what do we do? Should we make them to physician DNR? And there was a lot of moral distress. So I don't want to monopolize this, but it's definitely something that is a topic of interest. And I also think now that the curve is, not everywhere the curve is flattening, but in New York City, definitely New York State, things had kind of settled down a little bit. And I think that this emotional health of staff, frontline healthcare workers, and institutions, patients, families, everyone is a huge issue. And I think part of the disparities discussion, the George Floyd and the riots and some of the violence, I think also are connected to this. I think people are just not at their best. People are down, people are distressed. So how can we be there to help each other during this really tough time?
So while everybody's going to have a chance, everybody's on the panel going to have a chance to respond. I want to encourage those who are in the audience to get your questions in, which we'll try to deal with in the last 10, 15 minutes. So I don't know who wants to go next.
I do know that it was very stressful for a lot of family members when they lost one of their loved ones, that they weren't able to have a funeral as they would in normal times. And in our community, it's very important that, there's a processional, there's music, there's celebration of a person's life, and people just weren't able to do that. And so I know that now, since things are kind of getting better, a lot of the funerals are being held online, and it's kind of like a virtual type of thing. But people are able to celebrate in a person's life in their own way by via social media. And so for me as a chaplain, when I go into the room and sometimes a family member might be on the other end, and they request sometimes that I play special music, because I'm also a singer. So I will sometimes sing to the patient, or I'll go on YouTube and find some sort of special inspirational music. And really those little things make the biggest difference in a family's life.
Absolutely. One other thing I was going to add, some of the unsung heroes are our interpreters and patients who are, not Spanish speaking or not, English speaking, the two languages I know. And so, in sharing with them prior to having any of these major heavy goals of care discussions about what we're going to discuss, because you can imagine they go from one case to another case to going into an end of life discussion, talking about some of the heaviness that we do discuss in those consults, that you could just see them breaking as they're sharing this information for the very first time, and hearing that, and then all of a sudden having to relay that to family, hearing the distress and the crying and moral existential distress that the families are experiencing. It's so much, very heavy. And so, like Amy, like Melody, and many others have been saying, being there for one another is critical. And, knowing what we go home to and how we fill up our cup is so important. I have my wonderful and very beautiful, supportive wife and 5 little ones. That's what gives me rejuvenation and my faith, my evening walks. So whatever it is that fills our cup back up, we need to try to do that and have grace with each other. Sometimes it's your colleague's turn to take the next consult, but you could see the heaviness and you say, it's okay, we'll take the next one as well. So no worries. And having each other's back is so important.
I wanted to say one more thing. I was thinking about all of the different workers at the hospital, more than just the medical workers. I'm talking about the secretaries at the desk. So many of them, they have just, they've been going through a trying time because their kids were out of school and they didn't really have babysitters, but they needed to be at work. And that was hard. So a lot of times they would pull on me and ask me to meet them in the waiting room, and they wanted a little bit of prayer. They wanted some support because we can't forget those workers. We can't forget that they are the backbone, oftentimes, of the hospital.
One of the things we did that might be of some help is to monitor, and we did anonymous, regular surveys of the level of burnout of our 3 teams. In our department, we have a clinical team, a research team, and an administrative team. And we monitored their level of burnout and their level of distress. We also did a survey of working from home, what was good and what was bad. And that is, again, anonymous, because that helped everybody was able to see how everybody else felt about working from home. That generally was amazingly positive. And the third level of survey was surveying our patients about how did they perceive this transition towards virtual. We did it first in Wuhan because a fellow of mine went out there. She was lucky enough to get there maybe a month or 2 before everything broke apart. So, but the fact that I had a fully trained fellow there helped us survey the patients. And the patients really loved having their doctors wear their masks and do virtual care because they felt it was pragmatically important, but it was also symbolically important. They were concerned about them. And we did the same thing here. And we felt that the team felt quite reassured by the fact that patients loved the fact that we are giving them that type of protection. So sometimes collecting some data by monitoring and surveying and giving that feedback to the team helps the team understand that what they're feeling is similar to others, and that the patients and families really appreciate our level of care, even when it's so different from what we're used to.
There was a question about communicating advanced directives earlier, and I wanted to comment about this because I think just wanted to put in a plug for having advanced care planning discussions in all patients, preferably before they hit the hospital, and not waiting until they're needing a ventilator to have those discussions. And I think here at our facility, that's a cancer center, I was kind of harping about this. I've been harping about it since before the pandemic, but it took a pandemic to get us to get attention on having these goals of care discussions. And through our ADCC group, which is a national cancer group of the top cancer centers, several of the groups actually mandated that advanced care planning be documented. And now we're actually looking at these things as an outcome measure that will be monitored as far as including training for advanced care planning discussions. And so I think COVID almost jump-started this a little more, put a little bit of emphasis on it. And unfortunately, New York State did not give us any guidance whatsoever on how to handle these crises if we're running low on resource allocation. And so we felt that we needed to come up with our own protocols that were fair and equitable and to help reduce bias or disparities, because if you don't have a protocol in place, then things could just get biased. And so other states put these in place. Unfortunately, New York did not, and that created a lot of tensions across the state, forced us to actually, it was a good thing, silver lining. This group formed as a result of that. But I drafted this policy. It never ended up getting used, but it was something that looked at different things that a patient could have that could point towards a poor prognosis, somebody who may not survive COVID. But these are really distressing things to have to talk about or think about. But wouldn't it be ideal that this was more universal, that these things were being talked about earlier in all patients? So that definitely, I think, was something that came out of it in the realm of palliative care.
BJ? BJ?
Sorry, I was looking at the chat window. I think there was one question about drug policies and opioid shortage. So I just want to go back to that. I think the person who had put in that question had said that they are concerned about the opioid analgesics are so important, and that they are worried about the strict drug laws may prevent easy access to analgesics. And that's a real fair question. And I think even beyond opioids, I think we are really worried about the drug shortages across the board, right? Starting from remdesivir to all of the medications, and what does that mean? And how, if you have if you have less medication and more people who need it, how do you stratify? What is the ethical concern there, or the moral obligation? How do we decide who gets what? And what do we do is the question we have now. I hope we learn from this, and in the future, we don't have PPE shortage. We don't have medication shortage. The only unexpected should be another virus from somewhere else that surprises, not the lack of PPE, not the lack of medications, because those things are in our control. Viruses, we haven't controlled yet, but the rest we can.
So one question from the chat: how do you all see the field of palliative care changing when this pandemic is over? Big question.
I will say that I feel much
That's
more.
from Amy Scharf.
I'll just say that I feel much more closer to all my colleagues. This group is case in point, the people who are watching us. So I think it's bringing us closer in a way, and I hope we can keep this closeness and learn and grow from it.
I think that it gave us positive press, I guess, and some clout. I think making the case, we've always struggled to make the case. You talk about, CAPC, Diane Meyer, make the case to your administrators. And I think it gives you a seat at the table. It gives us a voice, gives us credibility. So I think that the number of consults we are getting is skyrocketing. And they're all saying urgent, urgent, we want you urgently. And, then we can try to educate them when we go and try to teach them some primary palliative care. And I think that they're seeing the good work that we do.
I think one of the things that hopefully changed is that our colleagues, our disease-oriented colleagues, are understanding that this is not easy. This is complex. This is not just touchy-feely, and that you need a body of knowledge, and there's some complexity to this work. Complexity to complex symptom management, delirium, dyspnea, horrible pain, and there's also complexity to some of these conversations that needs to be learned, needs to be taught, needs to be practiced well, and needs to have a tertiary level. And hopefully that understanding will now lead to the creation of the structures, because you can't have processes without having structures, and the nation doesn't have structures. Therefore, I think the great opportunity is to have the certainty that no place that has an ICU does not also have a PCU, where people can die with dignity and comfort inside that big academic hospital. Personhood care at the end of life happens, that no ambulatory service exists without having a supportive and palliative care ambulatory service. And finally, that there is no medical school and no nursing school that doesn't have an independent palliative medicine department. So I think that if that happens, if those three things happen, then there was a real silver lining to COVID. If that doesn't happen, shame on us.
Eduardo, I completely agree. The only thing that I will say is we should be the ICU, because we are focused on intensive caring, and the ICU should be renamed as ITU, intensive technology units. So we need ICU.
Wonderful.
I wanted to just say, one of my fun memories of working with VJ and Dr. Hellenbeck over at Stanford in my training was this sense that we are these warm and fuzzy and very sort of kumbaya singing individuals in palliative medicine. We are not. We are ninjas. We are here to fight for you and with you as patients and families, and we are not going to let you go quietly into the night. That you will have, advanced trainings, and we're going to come at you with education. We're going to come at you with empathy. We're going to come at you with the importance of a tool set that you can portably use as you go to private practice, rural practice, academia. That's what we should be taking away from all of this, using telehealth at its finest, using ways to reach people across our states, across our state lines, and even our countries, so that we can bring together care that is not for the haves, but also for those who we call the have-nots. This is what I would hope comes out of this COVID pandemic.
Well, I'll take the warm and fuzzy for for you guys for spiritual care, because it's needed, because
Absolutely.
as a people, people need that. And by now we all know that medical care without spiritual care is like trying to drive a 3-wheel car. And so we need the warm and fuzzy also, so in a professional way. So we're going to continue to do that from a spiritual care perspective.
All right. Yes, you are.
So I'm going to give you 1 minute each at the very end, because we're at the 5-minute warning here in terms of our conference, to think about the bottom line of lessons that each of you has. One bottom line lesson that you've learned by this pandemic so far in our response to it. And we'll go in, I guess we can go in alphabetical order, Eduardo.
Thank you. Well, I think it's what I learned out of all this incredible mess is that perhaps the most important care that we can possibly give as palliative care teams is extremely good self-care. We cannot be there for dying patients and their families, for distressed and demanding sometimes colleagues, for our own families and our communities, if we do not have a robust program to take care of ourselves in our knowledge, in our psychology, in our spirituality, in our physical health. And therefore, it has made me reflect on the importance of being sure that we do take care of ourselves and our teams before we take care of our bosses and our executives and everybody else, as a way of really making sure that at the end, the patients and families get the care we need.
Amy, you're up.
Yeah, my motto is always to just kill them with kindness, give a lot of love, lots of empathy and listening, and getting to know people as a person. So I always lead with the social history. And like Melody said earlier, getting to know your patient and what makes them tick, and sit down with them and spend time with them. And so once you know that, you can find out, you may decide that you're going to actually be the advocate to, continue aggressive treatment. And COVID is not the same as other things. We've learned that it's a bit paradoxical to other diseases. So I think that, it's throwing some curveballs at us, and we've actually risen to that challenge. And I want to echo what Eduardo said about the resiliency and self-care, and how can we, care for our sick, dying patients if we can't care for each other. And so really just putting our own oxygen mask on and taking a break, stopping, smelling the roses, taking some vacation time, and just remembering that we're all human beings and we all need love.
Domingo.
Amen to both aforementioned, very eloquent and compassionate statements. The thing that I would say I learned the most about this, in addition to everything everyone else has said, is there is the huge need for team efforts. That this is not something that we as a palliative team can do alone. That in some hospitals it's a palliative MD and a palliative NP, or it's a palliative MD and a 0.2, 0.3 social worker. That will fall, because like a hand, we require all the different disciplines to work efficiently to make the magic happen. And that's what we want to do, is we want to give homage to our colleagues, work together with them, beside them, work healthily within our own teams, and really staff appropriately so that we can all take that much needed time for self-care and create resiliency. But this is something that I think we really need to build the models that Center for Advancement of Palliative Care and so many other organizations have said, which is to balance out a care team and then helping those who are our primary and secondary palliative care partners.
Okay, VJ.
Sitting as I am in the heart of the Silicon Valley, I would be remiss not to point out leveraging technology in expanding access and providing more care to our patients. So one thing that the pandemic has done is it's telescoped all of us by at least a decade in terms of how we've become tech savvy. And I'm not talking just about us clinicians. I'm talking about my 97-year-old patient who actually used FaceTime to call us. So it has telescoped our patients, and they've learned to use technology because we have no choice right now. And so we shouldn't quickly have amnesia and forget that. We should hold on to that and help technology, not in lieu of what we do, but in addition to what we do, in addition, in terms of education and in terms of the care we provide. And the last thing I'll say is, I'm going to take a leaf from, or a page from Eduardo's book and make a very strong case for research pilots, research at every level, community-based research, because the pandemic has uncovered so many research questions that need to be answered. We shouldn't wait for another pandemic to find all the answers. I think we should start now, and research shouldn't be only done in MD Anderson or in Harvard or Stanford or Rochester or Roswell or in certain places, or Columbia, of course, but it should be, research should be democratized. Everyone should own it, everyone should contribute to it, and then we'll all learn from it.
Melody.
Yep. I just wanted to say that as spiritual care workers, our job, our work involves listening and affirming and encouraging and supporting patients on their journeys. But more than anything through COVID, I really feel that we can never forget the unseen and the unheard struggling voices of other healthcare workers that are, not on stage and who are not in the front. We are there for everyone, and this COVID pandemic has really just impressed upon me even the more to invite those workers into our world, to stop by and to get the support that they need, because oftentimes they would come to work and they would feel like there was no one in the world to support them. And so spiritual care workers, we are there not only for the patients, but also for employees.
So I'll say as a bottom line for me, we're still having a lot of tension between primary palliative care and specialty palliative care. And that's a good tension because we have to train it. There's too much work to be done to have it be done by specialty teams exclusively. Having said that, that means a huge educational backup and then seeing the tougher cases that we're going to have to keep doing. The second thing I would say is thinking out of the box. If there's one thing this epidemic has done is said the box is changed. And we're going to have to really think out of the box. And it's great to hear the way in which you all are thinking out of the box to try to make things happen. And this is very much a work in progress at this point. And the third domain is caring for ourselves and each other. This is really a time where we both have to do that for ourselves. We have to model it. We have to teach others how to do it, because this is a bit overwhelming for everybody right now. And so we need all the support we can get and give. So I want to thank all of our panelists for their expertise and their sharing of their experience, and thank the organizers of this. I don't know if somebody's going to come on and say that we are signing off, but they're welcome to come on. But this has been a very interesting discussion, which I have enjoyed a great deal. And because you guys have done all the work, which really makes it very fine to be a coordinator. But thanks everybody for participating, and thanks to the moderator. Here I have from Lewis. Thanks to the moderator, panelists, and media and AV teams from Columbia University. So I think with that we will say goodbye. Maybe you guys will stay on for a moment at the end, those who you are on the panel. But say goodbye to everybody else. So thanks for participating. Thanks for joining us, and take good care of yourselves.
Safe.
Thank you, everyone.
Thank you.